Hello, everyone. Welcome back to TARTLEcast. We have a special guest here this morning from Well Life ABQ. If you are looking at the future of healthcare and really want to understand where it's headed and the possibilities that are there that are not completely draining to your entire wallet and also beneficial to your company at the same time, then you would look to Well Life ABQ. And Casey, the CEO, would love to dive into kind of the philosophy around what your company is looking to achieve, then how it executes upon that philosophy, and then really how you're using a lot of data to explain that sort of that personal interaction with those individuals that come in and not have a function of sick care, but a function of health care.
Right.
Okay. Does that make sense?
Mm-hmm.
Very good. So would you mind just tell me about yourself? No, I'm not interested in that. So what's going on here? It's like, let's talk about the philosophy.
She was a volleyball player in the army, right?
Yeah, let's go.
One little tidbit there.
I mean, listen, if you want,
an officer in the army.
well, then we should be saluting.
Yes, exactly.
Yeah.
Actually, Jason.
Yeah. I mean, listen, if there's a direct connection between volleyball and you being at Well Life, I'd love to know and how that drives to the philosophy. So,
Completely unrelated.
All right, perfect then. We don't even have to focus on it. So, key me
That's
in.
me squirreling, bro.
You're
Can you
useless.
turn his mic off?
I'm gonna have to cut him off in a second. And he's in the background of the video too. So yeah. So tell me about Well Life. Okay, first of all, why did you call it Well Life?
Oh, I just called it Well Life because I was coming from another clinic and they already had all the marketing stuff, and so I just used that.
So you took it from the other clinic?
I got permission, but
Oh, okay. All right, that makes sense.
Yeah.
So you left this other clinic previously, right? And so in leaving it, why was there a transition? What was the change here?
So that clinic is in Amarillo, and I was moving back here, and having spent time in integrative functional medicine where it's not just about the prescription or the referral or just bouncing people here and there and all over the healthcare system, it was very much about like, how can we help you be healthier? And so I knew after learning all that stuff and my eyes were being open that I could never go back to normal healthcare. And so when I moved back to Albuquerque, which is my home, I sat down with the doctor I was working with at the time and said, I can't go back. Now I know what's out there. And he said, why don't you open your own clinic?
Integrated functional medicine.
Correct. So instead of just prescriptions, we talk to people about their lifestyle and how that's impacting their health, and talking about their nutrition and where they should focus on. And we do advanced testing to help guide our treatment plans. And then supplements are involved in that too. So a lot of people's treatment plans are just all supplements, and that's driven a lot by their desires and goals.
Okay.
But we have that in our toolbox.
So this sounds to me as almost like it's allopathic, right? But you're almost blending it into, I don't want to call it like holistic medicine, but you have a holistic perspective of all these other things that are, inclusive in what it means to be a healthy individual.
Right. We're not taking stuff just from Western medicine. We're looking and saying, okay, well, this is integrate. We can integrate this as well because there's a lot of evidence around this and this and this. And the funny thing about it is when something becomes very evidence-based, it gets moved over into the Western medicine column, and it's acceptable at that point. But a lot of practitioners like us, we've been doing it for years before it becomes normal. Like vitamin D. 5 years ago, nobody tested vitamin D. And now it's pretty standard.
And so, okay, so then this is making a little bit of sense here. So let's use me as an example. Okay, so if you're going to do some integrative health assessment, how does that actually start off? So what data are you actually collecting in this process? So through a conversation. So what would you even start off with asking me?
It has a lot to do with what you're telling me about your health and how you feel.
Okay.
So that starts it. That starts the program. So
I
let's
feel
say,
pretty good.
So then we probably wouldn't dive in too deep because you feel pretty good. So why would we fix something that's not broken?
So then if you don't fix something that's not broken, do we look at like baselines then? At least collect that?
Absolutely. We would do the standard labs. And then a lot of our patients really like to dive in deeper. And so they're like, oh, I hear you have this nutritional test and it's very comprehensive. So some patients love it, even though they have no complaints about how they feel and energy levels and stuff. So they'll still do the test. And we find stuff. Absolutely.
Okay.
Yeah, there's hormone tests.
Yeah, we have some hormone testing.
Toxicity tests.
Heavy metals.
For metals.
Toxics.
Yeah.
Well, you're always sitting in the studio crying, so you probably needed that hormone.
Yes.
I need that.
Yeah.
Too much aluminum, bro.
Yeah, way too much. Yeah.
Actually, I was good on all that. I
Yeah,
was shocked. Yeah.
I'm shocked that Jason was.
What
so healthy
deodorant?
as well.
What deodorant are you
Do
using?
you use deodorant?
Yeah, but I get that at Whole Foods.
Do you use antiperspirant, or is it just deodorant?
I don't know. I have to look at it. It said hops on it, so I bought it.
I'm not even sure in this
It was
episode.
beer related.
Because you're a patient of Well Life, I'm not even sure where HIPAA starts and begins in this
Oh, he's
conversation.
given me permission. We're
So
good.
Yeah.
no, but I think that the question I have is, why is Well Life's philosophy so different
Well,
than regular
So-
healthcare?
yeah.
Okay, so we have
what's
our
that
philosophy. So we have like our healthcare philosophy, but then we also have to think about this business model. How are we going to deliver this to patients? What's the best way to do that? Well, 80% of this integrative stuff isn't covered by insurance anyway. So we stepped away from insurance and looked at it differently and found this direct primary care model. I shouldn't say we, I found this direct primary care model where somebody pays a flat fee every month, and we're able to deliver so much more healthcare to them because we're not worried about insurance reimbursements and, oh, I can't talk to you on the phone because I can't file a claim for that. And
So when you say so much, so I go to this monthly subscription model essentially with Well Life, and you say there's so much more of a delivery that happens in this sort of decentralized effort where you're actually empowering the individual to take care of themselves rather than empowering an insurance company to take care of them.
correct.
So tell me about what's the difference here?
So I think everyone listening can agree that insurance does not equal healthcare.
No.
That is not. They're not interested in your healthcare. They're interested in paying as little as possible while you're a plan member.
It's a reactive system.
Very. So like just IUDs, for example. IUDs last about 10 years. It's birth control. Insurance companies hate paying for that. They're forced to pay for it because in 10 years, even 5 years, you're probably not going to be a plan member and you're still benefiting from something. So they only like little stuff. They only like the only what they have to do, the bare minimum.
If I get like a screw through my hand or something,
Right.
pay
They
once, get them out
They
of here.
have to handle that. Yeah. They're required. And if they weren't regulated by the states and stuff, they would get away with all kinds of things. But anyway, to answer your question, so when someone pays a flat fee and we pull them out of the insurance model, we're now able to say, yeah, come on in. We have space available because we're not fully booked because we leave space open for people to get in right away. When you come in, we're not double booked. We're not running an hour behind. You come in, you very rarely spend any time in the waiting room. You're right into the exam room, and we call it more face time, less wait time. And when you're in front of me, your appointment slot's 45 minutes, whereas a typical doctor's 15.
I got to tell you, I'm accident prone, Casey. And the amount of times I've been in a hospital, I guess too many to count or even to remember, depending on the situation. I maybe got 3.5 minutes with a doctor. And then everything else is channeled through all these other people.
Right.
I don't know what's going on. And then I get some fat bill on the back end. Not that I wanted it. It's just the circumstances of life, and getting injured, whatever that might be.
Right.
Now, here's something interesting that I'm looking at here. So, at TARTLE, we work with, companies in healthcare. And now when you look at a hospital or any of those sort of large providers like that, they want to bill a medical code.
Right.
They want to bill as much as possible. The insurance company does not want to pay out. So right now I have this logical, issue that is just like, compounding into this sort of stalemate that inhibits any sort of momentum, right? For getting things done, actually keeping people healthy or trying to help them in any way, shape, or form. So that's like the first issue. But from the way I'm looking at this here, you've looked at the model and said, well, forget the insurance. Let's look at the individual for the benefit of the individual. Let's put them first before we actually look at the profits of our company.
For the routine chronic care management outside of the hospital.
No, I understand that. I mean, emergency room's an emergency room, right?
Yeah,
but everything
healthcare
else
is not expensive. And anybody listening is probably thinking, well, of course it's expensive. Like, look at the cost of everything. But it's actually because we don't have price transparency. It's because the insurance claims are marking things up because nobody knows what anything costs.
Now, do you share that data, especially that pricing data, to these people that come in and say, okay, if I am looking at some sort of chronic long-term care, will you show me what this cost is going to break down to?
Oh, absolutely.
And
we're totally against surprise bills. We're all about transparency.
And now, is there, do you show it comparatively to almost like what you would be paying by going to the hospital?
Sometimes we can. Just it's a little case by case. But let's say somebody needs a certain prescription. Our system is designed. We'll pull up the prescription, and our system will actually tell us what the average cost is, the pharma price. And so we can tell the patient in very real time, like, if you get that prescription through us, it's going to cost you this much. If you go to the pharmacy, it's going to cost you this much. Or I'll tell people like, hey, I know you have insurance, but if they tell you it's going to cost you more than this dollar amount, let us know because we can fill it for this dollar amount.
Right.
It's dramatic too, bro.
These are people with insurance.
Do
that I
some
can save them
examples
money.
of
Really?
how do some examples of how the cost difference is if you go just pay for it out of your pocket compared to using.
So recently we had a patient on a blood pressure medication, very common one, a very cheap one. And we were able to get it for her for about $12 for 90 days. And I said, if you go to the pharmacy and you pay more than that, well, if her copay is $10 times 3, because it's a 90-day thing, that's $30 every 90 days. And we're saying it'll cost you $12 here.
So by removing perverse incentive structures of insurance and hospitals, them billing and not wanting to pay out, opening up the efficiencies of people to actually get to that resource to make themselves healthy, whatever that prescription may be, you have the ability to decrease the cost dramatically beyond what their insurance would already pay and having to ask for any sort of reimbursement. And they're willing to pay that out of pocket because of that change in cost.
And they're done. It's paid for. They've got their prescription. They're done.
Okay, so that model, that seems...
And they don't even have to go to the pharmacy to pick it up.
I'm going to throw this stage.
Yeah, I just ran in and grabbed it from your nurse practitioner, the prescription. It was just laying there.
Oh,
That's fantastic.
Right. Yeah, we just had it waiting. Like Jason recently filled a prescription. It was just waiting for him, and he picked up. We can mail it too.
It's my psych meds, bro.
Yeah, I bet it is. It's all those lithium pills for him.
Heavy duty.
Big time lithium pills for Jason. Yeah.
I need it all.
So you're this is fantastic. So you go through all of these different reports and studies for individuals. You look at data here in 2 different formats. So I want to break this down into both these formats. Let's start on the first one. How do you choose when looking at data, if there's research being done on a specific procedure or, a diagnostic thing for the human body, whatever that might be, what's the decision mark or benchmark for you as a company to say, okay, we should start using this sort of testing? What is the data that you're looking at, and how do you say, is this legitimate? Does this make logical sense for us to adopt this into our workflows?
I don't think I understand the question.
Okay, so you were talking about let's do
hormone testing.
I'm a very simple person.
Yeah,
so
no problem.
let's do hormone testing. So what would make you check people's hormones? What's the reason? Because the regular doctor, they're not going to do that unless you...
Well, how do I know what's the right test? How do I know what's the right way to read it?
Oh, I see what you're saying, yeah.
Okay, so something's going on in China, right? But it takes 30 years for us to adopt it over here in terms of our medical practices. Mm-hmm. What sort of benchmark? How are you looking at data outside of in the research field before you come over and then start to translate the information you're getting on your patients back to them?
Ooh, that's a big question. So things filter into my brain just like anybody else. Everything's yelling at you through email and social media and stuff. And there's some trusted labs that I have that I go to their webinars. My nurse practitioner goes to their webinars and we'll incorporate that stuff. If there's evidence behind it, we start to bring it into our practice and offer it.
How much evidence is what I'm trying to get at, right? So
the labs that I trust, if they're offering it, I'll probably offer it.
Okay.
Because I trust them.
Okay. So just through their own,
There's also a direct primary care, because that's what this is called. There's a network of them. Mm-hmm. And in that network, they're sharing information amongst each other. So, it's almost like blockchain.
So you're saying that there's a benefit to sharing data amongst yourselves?
Oh, absolutely.
That's really interesting.
We compare notes all the time.
Yeah.
Absolutely. But
as
let me clarify one thing. So the integrative health model is what we deliver. Direct primary care is how we deliver it.
Oh,
so they're very different concepts.
Okay, explain those two.
Because not all direct primary care. Some direct primary clinics are completely Western medicine.
Can
they
you
don't
please
offer any
separate
of this
the
other
what
stuff.
and the how then for us? Well, not just for us, but for all the people in 175 countries that are listening to this.
Right. So I've chosen, because I've learned and my eyes have been opened in terms of integrated medicine, that I can bring in all this other stuff into how I deliver healthcare and what I deliver. What I deliver. Direct primary care is the model that allows me to deliver that to the patient.
Okay.
With that subscription base.
In a 15-minute appointment, I can't go over advanced labs. I can't dive in deep. I can't keep you within my clinic because I just need to refer you out because I don't have time to deal with your complicated thyroid.
That's typically what happens.
But in the direct primary care model, it allows me and the patient to have this perfect storm, really.
So a legitimate doctor-patient relationship.
An actual relationship.
Through that model of direct primary care.
We so very rarely, we only refer out if we're out of our realm. We really don't know what to do with you next. That's the only time we refer you out. We have tried everything up to that point. So an example would be a patient comes in with a mole. Well, it takes too long to remove that mole. So a lot of times a primary care clinic won't remove the mole. They'll send you to dermatology. But it is completely within our scope of practice to remove the mole.
I mean, I would have cut the thing off with a knife myself.
Right. A lot of patients will do that.
Yeah.
So we're just going to remove the mole. And usually we can remove the mole at that appointment because we have plenty of time.
That's amazing.
Think about the cost, though, to go to a dermatologist
Right.
Just
from that one visit.
Just logistics and then getting that set up and then the amount of time wasted in between.
If the company is paying for all this health care, if they're a direct primary care member, they've put their employees on our program, there was no copay, there was no claim filed to see us, and we have not sent them to dermatology. So now there's no specialist claim either. We've removed the mole, they're out the door. There was nothing, no claim filed. The employer didn't pay anything, neither did the employee.
So you got economic efficiencies. You can typically get things done day of in that specific appointment. Mm-hmm. And then now let's talk about, I've removed that mole. Okay. Mm-hmm. Do you guys do analysis on that stuff?
Oh yeah. Send it to the lab.
Okay. So you send it to the lab.
Yeah.
How many data points typically come back on something like this?
So we send it off to the lab, and it's $65 to do pathology, simple pathology.
Yeah.
So that's what it's going to cost. Whereas if somebody's going through the insurance thing, I have no idea what surprise bill you're going to get 3 months, 2 years later.
Interesting.
For that stupid mole. When it's $65, and if the company's paying for it, now they're paying $65 instead of $200. Because we never filed a claim. We just said, company, it's $65. That's what it's going to cost you.
And this is really, really interesting as a company, because, there's two CEOs here, but explain the whole, like when you go into a company and you go over their insurance and like what they don't realize that they're paying for and how, I want to use the F word, but how screwed up it is, how screwed up the insurance is.
Oh, the insurance, they've trained us very, very, very well as consumers that we need them for routine stuff, where when we have car insurance, we don't expect the car insurance to change our tires or change our oil.
I change my own oil.
Right. We don't, that's routine stuff. We don't need insurance for routine stuff. We don't.
And if I go to use it for routine, it's going to cost me a fortune.
If you go where?
Use that regular insurance for routine stuff, it's going to cost me a fortune.
And good luck going to a doctor's office that's not a direct primary care model and say, how much is this going to cost me? In fact, I just took my mom to Colorado for a doctor's appointment, and she had to go in and she had to pay 2 fees because one of the games that clinics plays is they're tied to a hospital, and so they can charge a facility fee.
Sure.
So she had to pay, it was over $400 to see this doctor for like 25 minutes.
Really? That's like multiple months of grocery bill for people?
Yeah.
For some, even just, small, even like poor demographic families, like, come on, are you kidding me?
And it really frustrated me at that clinic too, because I'm like, I know if you file a claim for this visit, if you were to file a claim, you'd get maybe $150. And they have the audacity. They didn't have a cash price. They had the audacity to charge her that much. And the front desk people, they don't know. They're like, oh, it's going to cost you this much. Sorry.
So you've inverted this economic model with Well-Life. That's well and good. Now, so what I want to understand is the data is inherently so important for actually keeping people healthy and how you explain to them what that data means. For so long, it doesn't matter what the company is, whether it's healthcare, tech, I don't care. No one explains what's going on with the data. So if you're actually in the process of collecting and analyzing something, can you give me some sort of hypothetical situation of collection and analysis and then reporting that back to me? I want to know what that is like and how you guys are observing that data and using it.
An actual lab on it.
Yeah, use mine.
Jason did a hormone test.
Yep.
Mostly just because he's crazy, and so we wanted to see if. No, I'm just kidding.
That is true.
No, so we have the hormone test, and it's. I wish I had it in front of me because it is so in depth. I mean, it's 8 pages long. Normally when you get a hormone test, they're like, here's your testosterone level, here's your estrogen level, have a nice day. That's it. Okay. Ours is looking at, here's all your levels. Here they are in relation to each other. Here's what you here's how you metabolize those hormones, which is very, very, very important for your health. And then now I know, okay, this is how you metabolize your hormones. This is how I can best support you. Whether you're replacing your hormones or you're not, just using your own endogenous, this is how I can best support you. So a lot of times men particularly will come to me for testosterone replacement, but by the time we go through the test, I'm like, you really don't need replacement. We just need to block this little pathway here and it'll like stop your testosterone from turning into estrogen, and that'll raise your testosterone level. And they feel great. Like I've had people just feel great, and we didn't
instead of jacking their testosterone up to like 1,200.
Yeah,
because there's guys that are listening to this right now that's having that. They're just going in and getting injections or pellets or whatever,
right?
And then because you had a patient that was that way, their testosterone levels were through the roof.
I have so many stories of that, but
through the roof, and they're metabolizing it
all wrong.
Yeah, all wrong. So she's like, what? Like especially on the estrogen side of things, like me, I had high estrogen. Of course, you hear me cry and see me cry all the time, Alex.
Yeah,
So
that's fine. Yeah.
no, but I had high estrogen, so it's like, let's get the estrogen levels down. And she did it with supplementation,
Yeah, right.
that's taboo.
Yeah.
When we're talking about supplements, like vitamins.
Interesting. Yeah, and it's what I think is nice here is that you're not, like perversely incentivized to bill. You are incentivized to educate.
I'm incentivized to educate. I'm incentivized to keep patients healthy, because the healthier you are, the less you need us. Like, we're both like on the same thing. You want to need us less, and we want to keep you healthy, so you need us less.
So if I understand this contextually correct, you are meeting a stranger. They are allowing testing and data to be produced. They're essentially sharing that information with you. You are analyzing it and translating it back to them for their benefit.
Yes.
That sounds like a model for absolutely everything else that needs to happen everywhere across the globe with data. Does it
Data,
not?
Yeah, you're very data.
Doesn't that make sense? Well, you guys
Absolutely.
are extremely data oriented. You wouldn't be able to tell them anything if you didn't collect any data. You'd be staring at the person like, oh, you're healthy. All right, cool. See you on your way.
Right. I mean, so often with standard labs, somebody comes in and says, I'm this or that. And we get labs, we're like, you're fine.
Yeah,
They're like, well, but I'm not fine. Well, your labs say you're fine,
right.
but I'm not fine. and so that, that continues on, and they never get anywhere.
Correct.
Whereas they come to us and we're like, okay, well, your labs show this, but let's get some more information. Let's get more data
Yeah.
and see if we can find something and gosh, almost all the time. Very rarely have we ordered a more advanced test and found nothing.
No,
I can't even think of a single.
No, that's amazing. And honestly, if you consider that person who is the consumer of your product or service, for them, they have a perspective of value. And from what they were being told, it's like, okay, I'm glad something that has observed the mechanics of my body, whatever it might be biologically, is saying that I'm fine, but I don't feel fine.
Don't feel fine.
That goes for all things within any sort of consumer behavior, right? And I think that's been missed. And the fact that you're bringing the bridge with the data and also asking the person, well, what is really going on with you? Now we actually have a flavor of that situation that is really tuned in specific to that person. Whereas before it's just like you fall into a category of like, labs are fine, see you later, I don't need to deal with you.
Yeah,
You're in a bucket.
It's first person data. So I know you probably have an example. Of course, you can't mention any names or anything, but where somebody appeared to be fine, but they kept telling you that they weren't feeling good, and then you found something.
It's usually a nutritional deficiency. Sometimes it's hormones, but yeah.
Nutritional deficiency?
Yeah.
Like
So
me with my low vitamin B.
Right.
Would that be something? Yeah, it's very, very low. So I have to take vitamin B supplements.
Right.
Yeah. So which is a deficiency, but I would have never known that. But what are some of the things like, cause I think this is really interesting. What are some of the things that you see that can cause, like, studies have shown that can cause cancer or something if we don't fix it now?
Oh, so I'm my own patient on that one. So I had done the hormone test that we offer, and it showed that I had really high oxidative stress and very low glutathione levels, which is a major antioxidant. So I was completely asymptomatic.
Chicken noodle soup, glutathione.
I don't have cancer, right? That I know of. And so here I had this situation where my body was showing tons of stress, and at the time I was under a lot of emotional stress, but physical stress is, so people who exercise a lot, they can have some oxidative stress as well. But so they'd be healthy, but they'd still be way over on the oxidative stress markers. And the oxidative stress marker that I'm talking about is called 8-hydroxy. And it's an actual marker of DNA damage. Like, DNA damage is actually happening. And then it also showed that I didn't have the antioxidant to help myself. I didn't have enough. And so I started supplementing that antioxidant, and I flipped that now. So now my oxidative stress is down, and I have plenty of glutathione.
So if I understand correctly, you have preserved the cellular life and not allow it to ferment internally within the body because of oxidative stress.
Right. I mean, I was headed down a path of cancer, and you can't do studies showing like, oh, this person's going to get cancer. Like, it's hard to show preventative studies that, like, how do you know that person would have gotten cancer in the first place?
You don't,
like,
but you can.
But
I don't even want to have to show that they do. I'm worried about.
I'm sure not going to let that continue.
Yeah, correct.
My situation that I had.
See, and this is half the issue that I've looked at with data around social determinants of health, is that it's all reactive data.
Totally.
None of the stuff is actually proactive to say, well, how are we trying to keep these people healthy before even there's the placement of them becoming diseased or sick.
Right. I mean, vitamin C alone, the people that fight over whether vitamin C is helpful or not is just unbelievable to me. It's an antioxidant. It's a vitamin. Take it. Like, it's not.
If I don't need any more of it, I'll pee it out.
Right. It shouldn't be so much drama around it. A doctor that I'm a colleague with, he rounds in the hospital. He's an attending, and he ordered vitamin C for some COVID patients.
Mm-hmm.
He got like 6 phone calls. Like he had 2 vitamin C infusions for 2 COVID patients that were hospitalized, so they were severe. He got like 6 phone calls. But if he prescribes morphine, he gets no phone calls.
That doesn't make any sense.
It's horrible.
Last I checked, we bring like morphine on top of Everest if I'm freezing to death. You know what I mean?
Yeah.
But I can't get some vitamin C that was
vitamin C,
synthetically derived from whatever.
Oh, yeah.
Yeah.
Yeah, that's crazy. So
This guy's eating oranges. Somebody get on the phone right now.
Yeah.
I prescribed him 30 tangerines a day. We can't have that.
Yeah, no. We need to not prevent. That's not going to be okay.
So why does it benefit a company to use direct primary care?
Okay, so their employees are healthier. Just when we've kind of talked about that. So we're trying to keep their employees healthier. So just by that alone, they're more likely to be at work, less likely to be sick, be more productive, just that. We haven't even saved the company money yet, and I can, but I've just made their employees healthier.
Okay.
Just by a better primary care model.
And do you think you have a stronger ethical stance or even like a stronger moral stance than you typically find at a regular hospital?
So I don't like to bash my colleagues, but a lot of my colleagues are trapped in this other system and they don't know how to get out. They don't know that this other thing exists. And so all they're trying to do is survive the day.
Got it.
And I've worked in these clinics and it's awful. You're 15 minutes behind. Somebody's wanting to ask you more in-depth questions about stuff and you just don't have the time. You're like, you get one problem today. I can only address one problem.
Isn't that amazing? You can't actually meet the people where they're at in that old sort of system. But when you begin to essentially decentralize this market and invert a lot of that billing model that you would typically find, you can increase that quality of care to those individuals. Right. You can explain to people, frankly, what medical data means. So they don't go on WebMD and be like, holy crap, I got a brain tumor. Yeah. And that's what everyone does. Everything you go on WebMD, I got a brain tumor.
They have to check their boxes and make sure that they don't get sued.
But that's not useful, right? Because it's not a proper filter. So you, within your service model, act as a filter to help translate that data.
Right.
So for instance, if I'm using the TARTLE marketplace, I download my entire EHR record. Okay. And I don't know if you guys do anything with genome sequencing or anything, to substitute that, but I also do a food survey study on me. All right. And then I give you, other behaviors and I tell you about the quality of my mental state. I give you that data. You can essentially take that data, analyze it and translate it, and then bring it back to me and say, this is what we found because you chose to take your data and share it with us. Much like you coming into our Well Life ABQ and saying, hey, I want to run tests on me, and then I need you to give me some sort of insight so I understand what's going on with me. That's what I want to know. I don't care about the statistical probability of me being in a bucket and you associate me with a large group of people. I just want to know about me right here, my own statistics, not the statistics of that group.
Right.
Because that's
of what I could find on WebMD.
That's precisely correct. I am worried about me, the flavor of me, my priority. It's my health. Right. I don't need the relation to everybody else's health. Let me focus on this.
Yeah. So if somebody has this symptom, they can look that up and they can find everything online and they have this symptom and they have this symptom. But the hardest part about delivering healthcare is diagnosis. So everyone can look up, oh, I have this diagnosis, this is the treatment. But it's very hard to take, I have this symptom and this symptom and this symptom, put it together, and it's like, this is your diagnosis. Now we can move forward with how can we best help you.
So you're taking multiple, essentially disparate points that were otherwise separate from one another. You brought them together into a full body picture. You've integrated these things. Okay. And then you deliver the context of...
I'm so sorry.
No, that's fine. You deliver the context of that integration directly to those people.
Yeah.
So that's important. So you've actually taken multiple points of data sets and come to a real picture about what's going on.
Correct.
Okay.
So that's how...
Did you want to go cut that off? No, it's fine.
Will it cut off here in a second?
I don't know. Can you shut it? It should cut off in a second. But
no, that's fine.
I can't guarantee it won't happen again.
Yeah, that's fine. Can we throw it on Do Not Disturb?
Yeah, absolutely.
Yeah,
I would love to.
I'll leave a normal... We'll leave a little pause on the show right now.
Let's stop right there and we'll just do another one.
Yeah, part 2 coming right up.